Churches and faith-based nonprofits have a mission to serve, inspire, and uplift their communities, but managing finances can be overwhelming. That's where Jitasa comes in. Since 2008, we've helped over 1,500 organizations with bookkeeping, accounting, tax, CFO, and controller services, so you can focus on ministry, not spreadsheets. With values rooted in integrity, stewardship, and service, our team understands the unique needs of faith-based organizations. Visit Jitasa.com today. That's JITASA.com.
Hi, everyone, and welcome to Alzheimer Speaks Radio. I'm your host, Lori LeBay, and I'm so excited that you're joining us today. We are going to have a fascinating conversation, as usual, as we learn from people all around the world at all ages and stages of life. Stay tuned as we shift our dementia care from crisis to comfort.
Here we go. What you think about, you will bring about dementia change. We will.
Hi, everyone, and welcome to Alzheimer Speaks. Today, we're going to have a conversation about what is the history and science of Alzheimer's disease. And we have a researcher from over in the UK that's going to join us, which is always great. But before I introduce you to him, I just want to give a shout out to remind people that Mods Awards is taking applications through May 19th. So that deadline's coming up pretty quick, both for individuals and organizations, where you can win up to $5,000 or $25,000 for a organization for work you've already done. So that's pretty cool, and you can spend it however you want. I also want to invite people to Arthur's Memory Cafe. This is something online that we provide, and that is the second and the fourth Wednesday of the month from 1 to 3 p.m. Central Time. So if you're interested in that, just email me at lori@alzheimerspeaks.com, and I will get you that information. If you live in Minnesota, I also do a support group the last Wednesday of the month from 10 to 11:30 called Caregiver Connect out in Shoreview, Minnesota, and you are more than welcome to be part of that. And of course, we always welcome people to go and check out alzheimerspeaks.com, especially for all of our free educational resources. And then Dementia Map, which is our global resource directory. So with no further ado, let's introduce you to our guest. So, Michael, I'm so excited to have you with us. I can't wait to have this conversation. I think we're going to answer a lot of questions for people, and we're going to highlight your book. But I'm going to have you introduce yourself to our audience, if you don't mind.
Yeah, I'm Michael Hornberger. I'm a professor of applied dementia research at the Norwich Medical School at the University of East Anglia in England.
Okay, wonderful. Now, I always ask all of my guests if they've been personally touched by dementia in their own family or circle of friends.
Yes, yeah. My grandmother had dementia, and so I followed that journey on a non-professional level through that. And but of course, with our research, we are touched by so many people we meet all the time who are generously giving their time to help us with our research.
Now, you have written the book Tangled Up, The History and Science of Alzheimer's. What made you decide to write the book?
Yeah, I think that decision is quite a few years back, where I told my wife, somebody should write a book really explaining the science behind the disease for lay people. And she said, well, you should do it. And I said, no, I don't have time. I can't do it. Somebody else will do a much better job. And then the COVID lockdowns hit. And suddenly I had some time during the first COVID lockdown. And I started writing. Of course, it took them much, much longer to write the whole book. But really, that's how the idea was born, that I really wanted to explain a lot of the definition of dementia is very generic, that people say it's the changes to our mind and our cognition. And very often people say, well, why is that? What is actually happening in the brain? Why do people show certain symptoms and not others? And what is my genetic risk? What's the evidence for prevention? So I thought, well, maybe I put this together in a book and try to make it as lay-friendly as possible. That was, frankly, a very hard job to do because we scientists, of course, like our jargon. I happily admit that. But I think it was a great experience really to write this book. And I had it in the end. I wrote the first draft, and then I gave it to lay people and also some people with dementia and some carers to read. And that was again very eye-opening to get their feedback. And that took us several revisions. And hopefully we came out with a good product that's really will help people to have in a condensed form where does this disease come from? How does it actually, what happens in the brain? How does this cause the symptoms? And that's how I guess the origin story of this book.
Okay. So, yeah, so I can see how it can be different than a lot of other books out there. And I like that you gave it to a wide range of people because, again, we all look at it different. I interview a lot of scientists and researchers, and sometimes I'm like, okay, you got to explain what that means now. We all don't know the acronyms, and we don't understand the big long words, and and so that gets tricky to do.
It does. We like our big long words. That's the problem,
And you can pronounce them, and the rest of us can't. We just kind of with that. So wonderful. For your writing style, how would you term that in terms of how you laid the book out?
So for me, I think my writing style is really that I write in the first person plural, so it's all we, because I really want to take the reader on a journey with me to explore it. And that's really important. It's not that I tell people what they should know or that I teach them in a way, but I take them on a journey of rediscovery, which I did myself. So I went through all the original studies, all the original papers, went all the way back to the beginning, and to really rediscover myself. And that's really the writing style I try to emulate, to take people on a journey with me.
Well, why don't you tell us who the heck discovered Alzheimer's disease and how this all came to be? How, everyone's always amazed on where did I get these names,
Yes, absolutely. Well, so this is my other benefit. I'm German, as you might hear from my accent. And so Alzheimer's disease was first described really scientifically by somebody called Alois Alzheimer, who was a German, psychiatrist, neurologist, I don't know what you want to call it. At that time, they didn't have those labels yet, but he worked essentially with people who had changes to their brain. And Alzheimer, he was at the end of he was born in 1864 in Germany, in Bavaria. But really the critical part of his life was in Frankfurt in Germany, where he was at a clinic, at a hospital working. And that's where he met lots of different patients, essentially, and he described them in meticulous detail. So I went through the original files. You can actually still see some of the original patient files, his interviews. You can literally verbatim follow what he asked, what they answered. He wrote it all down. It's pretty incredible. And so in the beginning of the 20th century, he met one person called Auguste Dieter, and she piqued his interest because she had, for him, very interesting symptoms that she really forgot very quickly information that he just talked about with her. And but she was, in general, she was quite disorientated where she was. And he became very interested in her case and thought that she might have a form of dementia. So dementia was known already at that time. But what Alzheimer then next did, or after Auguste Dieter died in 1906, he actually investigated her brain and found in the brain very specific changes So two proteins he described for the first time that really are the cause of Alzheimer's disease, we think, these days. And so he was the first really to make that link between the symptoms of the disease and what actually happens in the brain. And that's why we named the disease after him. He was a very modest man, actually, but he was also a very cheeky man, apparently. So the more I investigated that, he was nearly kicked out of university because of all the pranks he did all the time. And he loved his family. He had three children, loved his wife, who died very young, unfortunately. And then he brought up the children himself, actually, while working. And he was also very modest. He didn't name the disease after himself. Instead, it was one of his mentors, Emil Kraepelin, who was a very influential psychiatrist at that time and he actually, in his textbook in, I think, 1910, he called it the first time dementia of the Alzheimer type. And that's how we know what Alzheimer's disease is. Now, the most interesting part actually of this is that Alzheimer always thought himself that these were just some interesting cases he observed. So for him, this was never a groundbreaking discovery. And if you read his obituaries from his colleagues as well, none of them actually mentioned those cases of Augustito or others he described of what we now say is Alzheimer's disease. So at that time, it was not realized that this was a big disease. And I think he would be absolutely amazed to know that people talk about his name now all the time with this disease, because he didn't think it was that big at that time. And the various reasons for this, we can talk about this if you're interested.
You know, what I find really interesting is you're the first person who I've heard say that the term dementia was coined way back then, because that didn't really come out until after Alzheimer's to the general population. And so a lot of people looked at that as almost a new term versus an old term of a subcategory, because it wasn't, I mean, everything was Alzheimer's for a long, long time. There was no, in the general public, from what I hear, and I talk with people around the world, dementia was kind of a new term for a while there, because it was like, well, what's this? Oh no, there's all different kinds of types now that we were hearing. And so that's interesting.
No, definitely. I think dementia, the term was around since the 17th, 18th century. You can find texts. Mm-hmm. So it's an old term, but it meant different things over time. So we need to be a bit careful with that as well, obviously.
Yep. Yeah. Yep. So, one of the questions people always ask is, and they get really frustrated with, especially families, why do they remember the old stuff and nothing recent? It drives me crazy. And I'm sure it drives them crazy too.
Yes, I think so too. I think so. It's a really common symptom which we see as well all the time, and I think for that we need to really explain how one part of the memory system works, which is really affected by Alzheimer's disease, and that's a region called the hippocampus in the brain. And hippocampus is nothing else than Latin for seahorse. Why is it called seahorse, you might say? Because the old anatomists, when they first described structures in the brain, they looked what the shape was of those structures. And if you take it out of the brain, it looks a bit like a seahorse. So there you go. That's the word for. So the hippocampus is a really important structure for our memory, how we memorize information. And it creates really, I would call it, index of our memories, so that you know where you have it stored in the brain. And so when you learn something, you create the index, and when you want to retrieve it, that index gets activated and the information is recalled from wherever it is stored in the brain. Now, the hippocampus is one of the earliest regions affected by Alzheimer's disease, and that's why people have these memory problems. But what we know is that the index for older memories is much stronger than for newer memories. So for newer memories, those memories never get properly laid down, or they're faulty, right? Because the hippocampus is not working properly. And that's why people have really problem remembering more recent information or events. Well, the index is really strong still for older memories because they've been laid down a long time ago, often recalled. And that's why people very often are very good at remembering still their wedding day. They have excellent memories from that, while what they did last weekend is very, very challenging for them. So it's this structure, the hippocampus, which gets affected by the disease, by two proteins. Again, we can talk about this if you're interested. And that's affecting this index. And the index just for newer memories is much more fragile.
So, what are the two proteins? I for our listeners who might not be aware of that.
Yes. So there are two proteins involved really in Alzheimer's disease. And again, I explained this in the book, what really happens if you're interested in that. One is called amyloid and the other one is called tau. And amyloid is essentially a protein that we need in our cells to work normally. And what happens is that when amyloid is at the end of its lifetime, it's recycled by the cells. But for unknown reasons, yet we don't know why, this amyloid sometimes gets cut into different parts which start sticking together, and it creates essentially a sticky mess outside of the brain cells. And if this sticky cell mess accumulates over time, it becomes toxic to the nerve cells. And that's one key aspect of Alzheimer's disease, that you can see outside of the nerve cells these sticky amyloid bundles, essentially. And that's Alzheimer already described them. You would see this under the microscope. The other one is tau. Tau is really a very important protein in the structure, keeping our structure of our nerve cells intact. And again, for unknown reasons in Alzheimer's disease, tau does not work anymore properly and disintegrates. And with that, the nerve cells start collapsing. And at the same time, there's a lot of amyloid around it. It's also toxic. So these two together, they really have this toxicity for the brain cells. And that's why the disease starts and then progresses, because the proteins accumulate over time.
Okay. So I know that there's been a lot of studies, that say this is it, but I also believe there was a study for the nun study that said, well, not so much in all cases. So what do you say to that?
So specifically, what do you mean that not everybody develops?
Yeah.
Yes.
So some people can have the symptoms and not have any amyloid or tau that's affected, and others, and vice versa. So.
Yes, I think what we think now, I think the consensus is that it's that you need both amyloid and tau coming together, which really starts the disease. So if you just have lots of amyloid in your brain, which we have when we age, we get more amyloid in our brain, you will not necessarily develop Alzheimer's disease. The same for tau. If you just develop tau, even though that's rarer, you will not develop Alzheimer's disease. But when the two come together, that's when the disease starts. And again, we do not know why that actually happens. There's a Nobel Prize to be won out there somewhere by someone.
Okay, well, wonderful. I'm going to just take a quick break here. If you just tuned in, we have been talking with Michael Hornberger, and he is an applied researcher and an author of Tangled Up, the history and science of Alzheimer's disease. And you can purchase his book on Amazon or Barnes and Noble and things. I just always like to give a shout out to my webmaster, because they're hard to come by for those that are really good. And these guys are fabulous. They're called Q for Good. And they are the first company that I would say really follows up, listens, dumbs it down to my level so it doesn't stress me out, so I understand. And they do everything in a really timely manner. And so if you're interested in finding, I hear people looking for people all the time, check out Q for Good. They're not in the US, they're over in India, but they are so fabulous to work with. I just can't say enough good things about them. So I want to get back to Michael here and ask a few more questions, because this has been very interesting. One of the things that I hear people ask about all the time is, especially when it hits their family, am I at risk for a genetic risk for Alzheimer's disease? And how do I find out, or should I find out? All of those things kind of tumble through the mind. What are your thoughts on that?
Yeah, again, in my book, I go through what actually happens with genetic risk. What are the genetic risk factors? What's the science behind it? Why does it actually explain? Most of them are really that they increase our amyloid in our brain, essentially. Well, there's pretty good news. So there are two different types of genetic risk. One is where you have in your family a gene mutation, which means that you will definitely develop Alzheimer's disease. And that genetic risk is very, very low for people. It's really rare to have that. We say usually less than 4%, so 4 in 100 people around the world with dementia will have that. So it's a really, really, really rare kind of gene to have. The other one is then there are other genes which we all carry, and we just have them as part of our genetic makeup. Mm-hmm. And some of these genes increase our risk for dementia. Others actually decrease our risk for dementia. So people are very often not aware that you can have also genes which can decrease your risk for dementia. And we carry them all, but it doesn't mean that we will necessarily develop dementia later on or Alzheimer's disease in the future. It's really that we, with our lifestyle and what we do, how we modulate our genetic risk. So it's really important to distinguish those two. So it's extremely rare that you have a genetic mutation in the family. And but if you're worried about it, I think it's always good to talk to a doctor about it. They will really only consider genetic testing and genetic counseling if you have at least 3 immediate family members who had dementia.
Okay.
And if they do, then again, there is a whole genetic counseling process ongoing. The reason for this is that your genes are not only your genes, but they're your whole family. So it will not affect only you, but everybody around you. And so it needs to be very, very carefully done. But the good news is, as I said, it's extremely rare to have that. But we all have these risk genes, which either increase or decrease our risk for dementia.
Well, it's interesting because I've never heard anybody really talk about the ones that can avoid or prevent,
Well, not prevent, but decrease. Let's not say
okay.
prevent. Yeah, but decrease, yeah.
But, is there research around that gene?
Yeah, there are, but they're rarer as well, you have to say. So, but there are people who have those, and there is some research happening for this. So, because it's clearly of interest to know what's happening in those cases.
Yeah, because I have not, I haven't heard a whole lot of talk about that. And I think, oh, well, maybe they would make a little faster progress on that one than they have on the other.
Yes. Well, you have to read my book then, Laurie, to find out more.
Yeah, we hear about the lifestyle things that people can do.
Yes.
But that is very, very interesting. So how do people reduce their risk if they don't have that gene?
Yes, exactly. I think we all know what we should be doing, and we've been told over and over again by our doctors that we should lead healthy, we should be more physically active, eat healthily, sleep better, and so on. And all these factors are clearly very, very important for dementia as well. Now, what they really mostly do is that, especially physical activity and diet, seem to be extremely good for our heart and our vascular system. And here in England, we very often say what's good for the heart is good for the brain. And that's a really important saying, because if you have good heart health or vascular health, you also will actually reduce your risk for dementia long term. And that's really important. And I'm actually writing at the moment a second book, which will be specifically about vascular dementia. So I explain all that in that next book, especially how the heart and vasculature affects our brain and affects our dementia risk. So you have to wait another year for that, Laurie, I'm afraid.
Okay, you're turning into a serial author, huh?
I do, yeah. Well, the other thing my publisher wants me to do to write a book about a biography on Alois Alzheimer. So I'm currently also researching that. So that's another one to come. But We'll
Okay.
see. We'll
Well,
see.
good, good.
But I think other factors, like sleep, for example, sleep is really important for us. If we have sleep, it can really help us. And sleep is very important to tidy up the brain.
Mhm.
So we talked about before that sometimes the amyloid accumulates outside of the nerve cells. It's during our sleep when a lot of the amyloid gets removed, actually, or tried to be removed.
Mhm.
So if we have disrupted sleep, that can really increase our risk for having more amyloid and therefore increase our risk for Alzheimer's disease. It doesn't mean that we will have it, but it just increases the risk. So good sleep hygiene is really, really important. And then lots of other factors, which again are more for our metabolic health, like having diabetes, having a healthy weight is really important. Even if we have that, it is really, really important that we take our medication as prescribed by the doctors. Because if you have like high blood pressure or diabetes and you are on medication, you're not necessarily at higher risk. It's only those people who have those conditions who are not either aware of it or do not take their medication that are at higher risk. So that's a really important message. If you have those conditions, really, please, please, please take your medication as prescribed by your doctor. It's very important.
Yeah, well, and I know being hydrated and stuff can be really important too, and kind of
Absolutely.
mask things or depression. What do you think about social engagement? I don't see too much in terms of studies. I'm seeing a few more of those coming in line. I'm a huge believer. My mom lived with dementia for 30 years, and I think she lived that long because she was socially engaged.
Yeah, I think there is something there with social engagement. We really, from the scientific perspective, we really don't yet understand it completely. But the evidence is there that people who are more socially engaged are usually can delay at least the onset of their dementia. Again, why that is, we don't know. But one hypothesis or one theory is that we are, because the social engagement, is very cognitively stimulating for us.
Mhm.
So we have to really pay attention. We're dealing with lots of things, and that really keeps our mind sharp. I think that's really one of the aspects, but it's just a theory at the moment. There needs to be clearly more research in that direction, but there is something there, clearly.
Yeah, and I might be mistaken, but I thought there was research regarding depression and purpose and engagement. And, could that be applied in this situation? Because so often people are misdiagnosed with depression. And
Correct.
to me,
Yeah.
it just makes so much sense. If it works over there, it's huge. I do some things with art and dementia too. And one of the things that um, people living with dementia say is when they are in the zone with art, their symptoms just melt away.
Yeah.
I
Yeah.
mean, and I just find that fascinating, kind of where they go and the ego has kind of left the building, so they're not so paranoid like the rest of us of what's everyone going to think of what I'm doing here, and not going to judge. They just kind of get into it, and I just find out that whole side really, really interesting, and haven't seen a ton of research in that area, and I think that could be. I would like to personally see some social prescription to,
Yes.
really get behind that to see if we can gather more fact.
I agree. For art in general, there is clearly a benefit for this. I think the most research has been done in music therapy, and
Mhm.
there's really good evidence for that, of course, that music therapy can really help. Just to come back to the depression, I think the depression again is interesting, as you say, because depression affects one structure in the brain, which is called the amygdala, which means just almond shaped. And the amygdala is just sitting in front of the hippocampus that I mentioned before, the seahorse. And the amygdala is really important for our emotional response. And if we are very emotional, we lay down memories because these are very often very important memories if we have a highly emotional event. But if we have depression, actually, very often the amygdala is subdued. And with that, our memory also is subdued. And we have actually poorer memory. And as you rightly pointed out, therefore, lots of people who have depression or even just depressive symptoms, not necessarily full clinical depression, they will have memory problems and they will think that they might have dementia. So, and it can be difficult to determine whether one or the other is the case because of that.
Yeah. I know for my mom for the first 10 years, and I mean, she's been gone for 10 and she lived for 30 years. So it was a long time ago. And they had a doctor that they had for like 40 years, and no one was really talking about it back then. And there really wasn't a whole lot of active research or conversation. But she was told for 10 years she just had menopause. It was just her menopause. And my mom would just say to the doctor all the time, this ain't my girlfriend's menopause. It's different. We talk about the symptoms. And then when her autopsy was done, I don't know if you know Bill Fry, Dr. Bill Fry, over here in Minnesota. Okay, I had him review the autopsy with me, and Bill just kind of gasped when he saw my mom's brain, and then he apologized. He's like, "I'm sorry, Lori," and Bill and I know we go way back, and he goes, "I have never seen a brain this atrophied, but you have said that your mom lived with this for 30 years. We found that she had Alzheimer's, Lewy body, and Parkinson's. The later two were never discussed with us at all." And he said, "This is what we should expect to see." Mm. But, I mean, he was in charge of a brain bank and never saw a brain, that shrunk. And so that was a really interesting conversation.
Absolutely. Wow.
We had that. No. And, I kind of knock on wood every day. I'm going to be 66 and my mom started having symptoms in her mid 50s. And not that I'm not seeing changes as I age, which, I'm not worried about at this point. I think they're, just more common things or too much multitasking going on. But, you kind of look over your shoulder, even though you think you're not. Mm. And I talk to a lot of friends that say the same thing. The other thing that I find interesting, and this will change over time now that it's being tracked more, but we've always heard for so long, or I've always heard from people, again, all around the world, that there's not that much history within a family that has been tracked. But I'll tell you, in my support groups, there's excuse my language, a hell of a lot more families with multiple situations of the disease that weren't named, but all had very, very common symptoms because, everyone was diagnosing it different, or wasn't getting it diagnosed. But I can't tell you how many families who have had multiple levels throughout their family, 8, 9, that they feel very firmly had similar symptoms. So I think some of that may change over time.
I agree. Yeah.
Churches and faith-based nonprofits have a mission to serve, inspire, and uplift their communities, but managing finances can be overwhelming. That's where Jitasa comes in. Since 2008, we've helped over 1,500 organizations with bookkeeping, accounting, tax, CFO, and controller services, so you can focus on ministry, not spreadsheets. With values rooted in integrity, stewardship, and service, our team understands the unique needs of faith-based organizations. Visit Jitasa.com today. That's JITASA.com.
Caring for someone with dementia is one of the toughest journeys, but you don't have to do it alone. I'm Allison Schreier, and my experience caring for my husband inspired me to create Zinnia, a therapeutic streaming service designed to support people living with dementia and reduce caregiver stress. Zinnia offers research-backed videos intentionally created for people with dementia, engaging, calming, and easy to follow. Whether you need to ease agitation, create moments of joy, or make daily routines smoother, Zinnia is here to help. Family and professional caregivers use our content to turn challenges into opportunities for connection. Accessible by subscription on mobile devices and connected TVs, Zinnia is simple to use whenever you need it. Because when caregiving feels easier, life feels better. Go to zinniatv.com and sign up for a free trial today. Use the code RESOURCE for 15% off an annual Zinnia subscription.
I think we'll have to think back the generations before us, of course. Most of them died because of cardiovascular disease, much younger. If I think back to my grandfathers, they all died of cardiovascular disease. Now we're very, very good at treating cardiovascular disease.
Mm-hmm.
and people get older, so we might see more people who actually have dementia in our.
Mm-hmm.
So that's one potential explanation why we're seeing now more people actually with dementia overall, because we're so good at treating cardiovascular disease, so people don't die of a heart attack or stroke.
Mm-hmm.
But we always joke, it's a terrible joke, but that life in the end is always deadly, of course. So we have to die of something in a way.
Yep.
And after cardiovascular disease and cancer, dementia is the top, top three one at the moment. So if we can treat cardiovascular disease, very good. If we can cancer, we're getting much better at this. So people live longer, and therefore, of course, they might have more time to develop as well dementia. That's one potential explanation.
Well, I found something interesting too. When my mom died on the death certificate, they said, well, there can only be one thing.
Yeah,
And,
yes,
and I'm
yes,
like, oh, that's a big mistake if we're trying to
yes.
track disease here.
I know.
And so, Alzheimer's got listed, but there was no mention of the Lewy body or the Parkinson's or anything else. And I believe that has been expanded now, so there's better data to be able
Yes.
to see, because do a couple combinations increase the risk, all of those types of things too are in the back of people's minds.
No, no, you're absolutely right. I think there's this myth that there are these pure diseases, but
Mhm.
I think very often people have a combination of things, clearly, and that's what makes it also so individual, what different conditions you have. So, yeah, I agree with you. Sorry, go
Yeah.
ahead.
I was just going to ask you if you can talk about the lesser known types of dementia. And are there different types of Alzheimer's disease? I hear people ask that as well.
Yeah, absolutely. So there are, and again, in my book, I go in the last chapter, I go into the lesser known, or very often they're referred to as rarer forms of Alzheimer's disease. And they range from very different, can have very, very different symptoms. So a condition called posterior cortical atrophy, which is again a long name. My apologies for that. But it's really, people have more visual problems in their disease, first of all, before they actually have memory problems. So very often they get their eyes checked and so on, but actually it's a disease in the visual areas of our brain. But it's again caused by amyloid and tau. So it is Alzheimer's disease, but in a way of a visual form. You can think of it like that. Then there's another form. Again, the names, sorry, get very complicated now, Laurie. I apologize. Which is called logopenic aphasia, and that's more a problem with language, actually, with speech and understanding. So you can think of it more as a language version of Alzheimer's disease. And again, very different, that people will have these speech or language problems and nobody would think that they will have Alzheimer's disease. But that's what actually, again, they have amyloid and tau underneath it, and it can overlap with other language syndromes like in frontotemporal dementia. And then there's these kind of diseases like corticobasal degeneration, and these are the people have more issues with their movement, and there can be more, so they have problems with their movements. And again, it's like a movement version of Alzheimer's disease. And for these different forms, it really just depends where these amyloid and tau molecules accumulate in the brain and what function that area has, and that will determine it. But why does it, for most people, accumulate in the memory areas first, and for other people in these language or vision or motor areas? Again, we don't know at the moment. We have to be honest about it. But for those people who have these symptoms, unfortunately, it can take them much, much longer to get a diagnosis and be treated. So, if you're again unsure, talk to your doctor. But sometimes if you have, especially if this one of the more less common versions, it really helps to get a referral to a specialist center where people might have more experience with such cases and can give you a better diagnosis. So I would encourage that people not to think only of memory problems, but again, you can have other symptoms for other forms of Alzheimer's disease, even though they're much less common.
Yeah, it's interesting with the aphasia, because I've had a few people in my support groups, with that, and how how jumbled the words get. And I mean, they're just not even connected to what they're talking about. But they can spit them out and they don't lose their cadence at all or their rhythm of their language. They just spit it out. And it's just like, wow. And what we all found was, because people who have speech issues are really embarrassed and don't think anybody can understand them. But what we found is when we really paid attention, we knew exactly what they were saying, a lot of the time. Now, as it progresses more, that becomes more difficult. But it was very interesting. It's kind of like when they have the words mixed up on the page, and can you still read the paragraph? And most of us can still do that. So it's amazing what the brain does. I'm wondering, with the one with the movement disorder, does that get mixed up with Parkinson's much, do you think?
It can as well, exactly. Or dementia with Lewy bodies, as you mentioned already.
Yeah.
So these are all very difficult sometimes to tease apart, actually. It really needs a specialist assessment for teasing them all apart, because they have specific symptoms, but also lots of shared symptoms, exactly. Yeah.
Okay.
So that's why, again, for the lesser common forms, they can overlap, like the aphasias, as I said, they can overlap with other symptoms from frontotemporal dementia, which can overlap with them, and that can make it very, very difficult as well to distinguish that specific form. In the past, that was not such an issue, but now, since we're having now treatments and drugs that are coming on the market, it will become clearly, because you want to know that the underlying disease is Alzheimer's disease, that you're eligible for those treatments, and that is clearly an important issue.
Yeah, I find, over the years, and I stepped into this formally in like 2009, how much the diagnoses have changed. Like initially, it was like, you got Alzheimer's. And it was like, okay, that was glued to you for life. And now, it went from Alzheimer's. And then I remember when MCI came out, mild cognitive impairment, and a lot of them got switched to that. And they were like all up in arms, rightfully so, going, there's nothing mild about this. First of all, it's a horrible name, because I still have my same symptoms. And now you're minimizing it. I mean, that's how they felt.
Very true.
And so, and now, and so many of these people have been, their diagnosis has changed multiple times, 3, 4, and even 5 times. And, many of them are getting so frustrated that they don't even want to go anymore, because they're not getting answers in terms of what can help. So now what I'm seeing is this broader term, Alzheimer's like, or, it's kind of this broad category, but no one's really, a lot of them are not pinning it down. But I still think it would be really helpful for them to tell people that this can be a fluid disease and it can change. And I'm not hearing doctors and professionals using that language. And I just think that would help families so much, because they're just, they like do all their research, they get all their stuff, and they're like, oh my gosh, I got to start all over again. I mean, that's kind of where they feel. And it's just a huge mental and physical and sometimes financial setback to go through that all again. And some
absolutely
of them are just going, I don't want to do this anymore. Now I don't. And there can be a kind of a buildup of distrust in terms of the physicians and the professionals giving these diagnoses, even when they go to specialists. That can vary so much.
Churches and faith-based nonprofits have a mission to serve, inspire, and uplift their communities, but managing finances can be overwhelming. That's where Jitasa comes in. Since 2008, we've helped over 1,500 organizations with bookkeeping, accounting, tax, CFO, and controller services, so you can focus on ministry, not spreadsheets. With values rooted in integrity, stewardship, and service, our team understands the unique needs of faith-based organizations. Visit Jitasa.com today. That's JITASA.com.
Caring for someone with dementia is one of the toughest journeys, but you don't have to do it alone. I'm Allison Schreier, and my experience caring for my husband inspired me to create Zinnia, a therapeutic streaming service designed to support people living with dementia and reduce caregiver stress. Zinnia offers research-backed videos intentionally created for people with dementia, engaging, calming, and easy to follow. Whether you need to Ease agitation, create moments of joy, or make daily routines smoother, Zinnia is here to help. Family and professional caregivers use our content to turn challenges into opportunities for connection. Accessible by subscription on mobile devices and connected TVs, Zinnia is simple to use whenever you need it. Because when caregiving feels easier, life feels better. Go to zinniatv.com and sign up for a free trial today. Use the code RESOURCE for 15% off an annual Zinnia subscription.
I agree. I agree because the diagnosis, is still done on symptoms. And when the symptoms overlap or change, it can change the diagnosis. We're moving now, of course, in a new era now that we will have, and in research they already exist, not yet in clinics, that we will have potentially blood tests in the future for specific type of dementias like Alzheimer's disease or other forms. So that means with a blood test, you could tell if somebody has which type of dementia, regardless of their symptoms. Which, whether that's a good thing or bad thing, I'll let you decide, but it's a different approach so that you can maybe combine as well the two, what the blood test says, what the symptom says, and it gives you maybe more precision. It's again important for us to know which are the underlying proteins, because those are the new drugs that are out there, that they are treating the proteins and not the symptoms. So we want to get the right drug to the right person with the right proteins, clearly. So that's important. But I agree, the symptoms are very variable and change over time, as you say, and it can be absolutely devastating for families when you have to tell them that, well, we think actually it's now X and not Y. And that's, as you say, you lose a lot of trust then. I agree.
Well, in the blood tests, I know people are really who have been through this and on this journey a while are not, the majority of them I'm hearing are not thinking that this is a good thing because of the distrust of the change. And they worry for people to get that labeled. What's that going to do to their insurance? Now they've got a pre-existing potential issue. Is insurance going to get involved regarding driving? Are people going to look at them differently? I mean, there's lots of different things out there, especially when this, in my opinion, I'll just speak for myself, but it's a science, but it's a crapshoot out there too, in terms of being defined and sticking to it. I mean, it just seems like things change a lot in terms of, you have this research that says this, and you have this research that says that. And then you have not always this consistency in terms of delivery systems and styles of how people are testing. And I know for myself, and I'm sure my doctor's going to be like, get that blood test, you're getting old, Laura. I don't know if I'm going to do it. Because I don't know if it's really going to help me live life better. And
I agree. Yeah. So sorry, I should clarify, Laura. I don't mean for people who do not have symptoms. I think it can really more help for people who have maybe a diagnosis and to confirm it. But I agree, even for them, it's not 100% clearly. Yeah.
Because I've heard that they kind of want to push it through for the majority anyway.
I know, but I think it's very difficult to do that, and there's a big hesitancy in the community because exactly of those issues you say. It has enormous, implications for people to have that as a risk hanging over them, for them, their families, their insurance, everything. But you can of course change things earlier. That's the balance to strike. But I think at the moment, everybody's just thinking about it as confirmatory of people who have symptoms, essentially, and then confirm it. Then I think that's a better first step. And then see actually how it really works in the real world, not in research, as you say. That's very often what we need to find out.
Yeah. So in all of your work, your research and even in writing the book, what's been the most surprising things that you've stumbled along in your journey?
Well, for the book, I think the most surprising thing I think there are two in the book. One is I discovered that actually the first person, August Dieter, was described by Alzheimer, it was actually discovered in the 2000s that she had a genetic mutation, and nobody knew that actually. Mm-hmm. And that was really fascinating. Very few people know that, and I hide it somewhere in the book. So yeah, if you read the book, you have to find that information somewhere in there. The other one is a bit of now more a tragic one, and that's I discovered that there was another person beside Alois Alzheimer who actually discovered the same disease at the same time, but it doesn't carry his name. He has been forgotten by history, essentially. And his name was Oskar Fischer, and he was in Prague at that time. And it's not clear why the disease is not called Alzheimer Fischer or Fischer's disease or whatever, but it's Alzheimer's disease. And Oskar Fischer, he was overlooked. He actually published much more on these cases than Alois Alzheimer ever did in his life. So there is a big irony in this, yes. So I have a whole chapter on him. And unfortunately, Fischer had a very tragic life because he ended up dying actually in a concentration camp. And as I said, was never recognized for anything. So in a way, it has become somewhat a mission of myself to raise the flag for him that he should be recognized as a person who co-discovered the disease with Alois Alzheimer and should be far more recognized.
Yeah, I agree. I did not know that. So thanks for sharing that. Anything else that you want to share with our community?
No, I think, if you want to, we're scientists, we might talk long words, but we're in general very approachable. So if you're really worried, always reach out. We're in generally, we're not sitting in the ivory tower only. We're very happy to climb down and come and talk to you, or you come talk to us. I think this is really important. That has really changed over the 20 years that I've been working in this field. We're really working on much, much closer together with the families and the people with dementia. And so that's super important. And so please, please, please reach out to us. We love to hear from you. And thank you again for giving me the opportunity to talk to you.
And, I encourage people to, get your book on Amazon or Barnes and Noble. You're also on LinkedIn if somebody wanted to talk with you.
Well, people can just Google me. My name is so unusual, so they can easily find me. If you Google me or reach out on LinkedIn, please be my guest. I'll be very happy.
Okay. And again, the book is called Tangled Up, the History and Science of Alzheimer's Disease. In wrapping, I always ask our audience to be a giver of hope. Like, click, and share, not because we're tracking the numbers, but because it really matters. There's not a good way to disseminate information to people in need. A lot of people still don't talk about it. They don't share what's kind of going on in their mind or their family. And the more we could get this information out into the public, the more normal and free and accessible it's going to feel. People aren't going to feel so alone and so ostracized, which often they do feel. So, it's not going to take much time. It's not going to cost you a nickel. Just be a giver of hope and share your knowledge. It's powerful and it's meaningful. So thanks, everyone. Appreciate your time today. Bye now.
Churches and faith-based nonprofits have a mission to serve, inspire, and uplift their communities, but managing finances can be overwhelming. That's where Jitasa comes in. Since 2008, we've helped over 1,500 organizations with bookkeeping, accounting, tax, CFO, and controller services, so you can focus on ministry, not spreadsheets. With values rooted in integrity, stewardship, and service, our team understands the unique needs of faith-based organizations. Visit Jitasa.com today. That's JITASA.com.